Hi guys. Um, Within our class, we really never have really emphasized as much as I think we should about patient history taking. When we take a history, it's kind of like we're being detectives. Whenever the patient presents to the triage office and complains of abdominal pain, what are the questions to ask? How are we going to process this from the time that they walk in to the time that they go either to the medical floor, to the way that they go to surgery, or do they go home? And so a good history is going to make you look really smart in front of the doctors and your other colleagues, because a lot of times your history is going to lead to the solution of the case, or at least the direction in which you need to go in order to further diagnose the patient, whether you need to order an abdominal x-ray, whether you need to do a CT scan, whether or not the patient has a history of Crohn's disease. So these are all going to be very important, deciding what the right body system is, kind of like the rooms in our Clue game. What is the right body system that's being affected? Is it the kidney in the abdomen? Is it their appendix? Is it Crohn's disease? Like a disease process. What is the weapon that's being used? Is it been trauma? Is it infection? Like C. difficile? And then at the end, who done it? What is the diagnosis that we have found to solve the case? Who done it? So this is going to be kind of a fun way to think of it, but you guys have to realize that your history can absolutely change the course of whether or not this patient gets, you know, gets seen quickly. There's things, that you will want a patient to be seen quickly for. So if you have a patient that comes in complaining of right lower quadrant pain, in your mind, you're going to ask a few questions, and as soon as you kind of get the answers that you're looking for that lead you down the path of maybe an appendicitis, that patient needs to go back directly. The patient needs to go directly to ER, go back to an ER room. Patient needs to go to X-ray. Patient may need to go to surgery. So just based on the questions that you ask, whether or not that patient gets sit in triage waiting, whether or not the patient gets taken directly back, is based on what you ask. So let's ask the right questions. And that we're going to have a little bit of fun with this. So we're going to tease out the differentials. I want you guys to know this word very well. The differentials. When I was working with a cardiologist once, he told me to have 10 differentials in my mind for each patient I seen. The best thing to do when we're looking for differentials is listen to the patient. Give them a chance to answer the questions, and silence can be golden. Because a lot of times, if we try to interrupt or we try to barge in too quickly, we may miss a key element to tease out the differentials. And so differentials isn't something we've talked about this semester too much, but we're going to in this little slideshow. Get the facts. Can you tell me more? I didn't understand what you meant by abdominal pain. Can you take one finger and point to it for me? Where exactly do you hurt? Take one finger and show me. What are you afraid of with this abdominal pain? Have you had anybody in your family that's had a history of abdominal pain? And always, if you can, look at what the last nurses put before you leap. Look at what the doctors put before you leap. Look what's been ordered. Look at the labs that you have back. 85% of the time, your history alone can provide the diagnosis, and you'll be right on target. So now you have to ask yourself, could it have been maybe an illness? How about a tumor? A blood disorder? Maybe it was genetic. Is it an organ failure? Oh, but could it be an injury? Yeah, maybe it's an injury. So we have to start to tease out these differentials. Maybe it was Mr. Body. Sometimes you have to think, maybe the butler did it. Maybe it's an autoimmune process. That's something to think about. You guys remember this guy? He is Mr. Body, I guess. What caused this injury? What was the mechanism? And how did it affect this patient? Where is the injury at? So what room are we looking at? Is it a blood dyscrasia? Is it a heart injury? Is there something wrong with the kidneys? Maybe they're not getting enough oxygen in the lungs. Maybe the colon is obstructed. What about a stroke? Oh, maybe it could be a zebra, though. There's a lot of zebras out there, and I'm Probably about the worst one for chasing zebras, because I guess I am kind of a zebra. Parkinson's at 36? Really? So could it be something totally that we didn't suspect? So Sherman, let's play. So earlier, Peabody saw Bowinkle at the cocktail party, but later that night, he presented to the ER with chest pain and hemoptysis. We have to rule out the differentials that have to do with hemoptysis and chest pain. Let's think. Let's see. Why would a nice young moose have hemoptysis? Hmm, so let's see here. What are my differentials? First I need to think about where is the blood coming from? If he's coughing up blood, is it coming from the esophagus? Is it coming from the stomach? Is it coming from the lungs? Maybe the heart. Maybe the heart's causing some kind of pulmonary um, failure that's causing pulmonary edema. Gosh, what diseases again could make you cough up blood? Tumors, infections. Could it be some kind of a torn esophagus? Some kind of trauma? Maybe he got in a car accident. Or what could have caused it? Did he get hit with something? Did he have too much blood thinners? Gee, let's see. What could it be? So let's think about the differentials that we could have for hemoptysis. Hemoptysis could be caused from trauma. He could have been hit with a lead pipe. He could have had a history of peptic ulcer disease or a history of upper GI bleeding. He could have a history of HIV. A nice guy like Bowinkle, who would have thought, huh? Bronchitis, lung cancer, pneumonia or infection, blood thinner. Maybe he's on an anticoagulant. Maybe that's why he's bleeding so much. Systemic lupus. They have pulmonary scarring. What about a pulmonary embolus? What if he's a drug user? People who inject drugs sometimes have hemoptysis. What about chronic liver disease? Maybe he doesn't clot very good. So then we also got to think about his other complaint that he presented with, which was chest pain. What are the differentials for chest pain? Once again, you got to think about cardiac disorders. Is it ischemic chest pain? Is it non-ischemic? Is it a cardiovascular problem? Is it an aortic dissection, esophageal spasm, esophageal varices? We know he's been drinking. Reflux, peptic ulcer disease, pancreatitis, pneumothorax, pneumonia, pulmonary embolism, musculoskeletal injury. And again, like I said, it could be trauma. These are some of the things that I use as tools to help me to rule out different differentials. I have a little book I keep in my pocket. It's called the Differential Diagnosis Pocket Book. And it's very helpful to help me to think of things that are more like the zebras, the things that you may not just automatically think of. If you look in the manual of medical therapeutics, the Washington manual, it also has things about hemoptysis. And it notes that it's a nonspecific sign associated with many pulmonary diseases, but it also could be hemoptysis, easily mistaken for hemoptysis, such as in esophageal varices or gastrointestinal bleeding. It also says hemoptysis can be from cardiovascular disease, such as mitral stenosis, pulmonary embolisms, and again it lists trauma. It also says about the possibility of autoimmune disorders, Goodpasture syndrome, systemic lupus, drugs or toxins, including drugs such as cocaine or even prescription drugs such as anticoagulation. And then I want you guys to always get into that routine where you learn to ask the right questions. What are you allergic to? What medicines do you take? What is your past medical history? These are definitely routines that you need to set into your mind. Another good book is a book about history taking. And it's a book that I just gotten over the last couple years. And it's also a good book that kind of helps you to rule out the different things that could be causing the hemoptysis or the chest pain. So let's keep on going. Let's not waste any more time. Let's get this moose out of triage. So let's not forget about our interrogation. Remember PQRST. What provokes his pain? I ask him. He says coughing provokes the pain. Alcohol makes it better. And when I cough, it gets worse. What does it feel like? Is it sharp? Is it dull? He says, no, but it's sometimes stabbing, and definitely it feels like a burning pain. And when I asked him if it was crushing, he said yes. Does the pain radiate? Yes, the pain radiates to my throat. And I say, well, can you point to the spot where it hurts the most? And he points to his mid-chest. On a scale of 1 to 10, with 10 being the worst pain that you ever had, would you rate the pain right now? And he rated it a 10. Then I asked him, when did the pain start and how long did it last? And he said,
And now...
Hey, Rocky, watch me pull a rabbit out of my hat.
So Rocky took his car keys and was going to drive him home. But then Rocky got distracted by texting about the party.
Ah, but remember, a fiend in need is a fiend indeed.
So now, after kind of getting the gist of the escapades of the evening and his friends kind of filling in the details, we know that he was involved in a motor vehicle accident. So now we need to start looking, what other history has he had? His past medical history does involve peptic ulcer disease. He denies HIV or bronchitis. He denies ever having a history of lung cancer or lung cancer in the family. He doesn't remember being around anybody with tuberculosis. And we're going to get a chest x-ray and a CT scan to rule out pneumonia. We should probably get some labs to see if he's on any blood thinners or that he doesn't have any liver disease that would cause him to have prolonged bleeding. We're going to get these when we order the labs. Does he have kidney disease? Well, we're definitely going to get some labs to make sure that he didn't also have some other injuries when he got into his accident. And lupus, I think we can probably rule that out because that's probably not the cause of his acute bleeding. Pulmonary embolus, well, it could be, but once again, let's go ahead and get the CT scan and see what we can get that seems more appropriate to the situation. And could he be a drug user? He could be a drug user, so we probably ought to get a lab panel to rule out any kind of drug abuse. And also, he is a drinker, so he could also have chronic liver disease or pancreatitis. So as we cut the list down, we can start to rule out the other disease pathologies.
Be sure to be with us next time for further adventures of Rocky the Flying Squirrel.
I guess we better get down to the lecture. But definitely don't forget the importance of your history, because you guys really, really, really got to put yourself, where you can pick up all the details. And when you get all those details, you'll know what test to order and things like that. So since now that I have your attention, we're going to go ahead and move on with our slides for the lecture.